So again, we talk about now the star of the show, that patient with the large vessel occlusion who might need an endovascular reperfusion. So what we talked about in the Comprehensive Stroke Center and the metrics, our particular journey, and I've talked to some experts here at Christiana, and I know your journey took 2.5, 3 years in order to prepare. At the University of Maryland, I had over 100 meetings over a 2-year period just to get people on board that this is a good thing to do. I'm still not sure if it's the right thing to do. That we have an additional, not only do we have the primary stroke center regs that we need to pay attention to, but now we have a whole layer of comprehensive regs. And what that really means is that our hospital is stroke ready for any neurosurgical patient or any patient who needs a neurointerventional procedure for 24/7. So one of my stroke doctors is here, and one of my mentors, Dr. Wozniak. She spoke this morning. She's probably the expert with thrombolytic therapies, probably in the nation. So if you have anything to add, please let me know. She's ignoring me, but she's really, really skilled. I'm leaving some time for questions. So really, bottom line is when we triage that patient, Dr. Dresser asked me to talk about reality-based transfer of these patients and what gets in the way of that. And so I think there are several different things that get in the way of that. But we do know that for the triage of the complex stroke patient, success is based on stroke therapies. It's time sensitive. There's a need for speed. You have to work quickly. I don't see across the nation the same need for speed taking care of stroke patients that I see when you take care of STEMI or trauma. And I'm just telling you it's out there. And we always compare it to those two things. I think with STEMI, it's much easier because you can see EKG evidence. With trauma, it's evident that they need a trauma center. But really with stroke, you have to think in your mind and teach your clinicians and teach your frontline providers that the potential for a catastrophic event occurs if we're not quick to reperfuse. So the basic algorithm really is the patient's found in the field. They go to the primary stroke center, and then they are assessed and decided, do we want to send them to a comprehensive stroke center? I'm going to tell you some of the national challenges that we see. The primary stroke center does not want to feel like Big Brother, the comprehensive stroke center, is going to tell me what I have to do. And that's real. I mean, I've talked to a lot of people over the last couple of months, and they really feel that they want to take the reins and making the decisions about which patients stay at their institutions and which patients may benefit from transferring to a comprehensive stroke center. They're not necessarily convinced that the risk-benefit ratio is worth taking the time to sending someone to a comprehensive stroke center. So we know there's a lag of translational evidence. We do know from the HERMES trial, which is I'm going to talk to you in a minute, there have been 8 trials in the last 48 months that really talk about how IA therapies are the standard of care. Just like IV TPA is still the first line standard of care, but if you have a patient with a large vessel occlusion, which we're going to talk about, there's no question about it, they need to be assessed to see whether or not they are a candidate for an intravascular reperfusion procedure. And we can talk about how you can do that at the primary stroke center prior to sending to a comprehensive stroke center. We need to improve the identification of these patients in some of our primary stroke centers. There are a lack of timely transfer protocols, and I'm going to talk about that in more detail in just a second. And sometimes there is a complete lack of communication between primary and comprehensive stroke centers. I think now in 2016, it's imperative that if you are a primary stroke center, you should be aligned with a comprehensive stroke center. You should know their leadership. You should have their numbers. You should have their emails. And it's a two-way street. They should also have yours. Because what you really want to know is you want to share your metrics, share the information, and share what happens with the primary stroke center once you've taken the time to send them a patient. And really, across the nation, it might not be a problem here, is a complete lack of neuro ICU beds. When a primary stroke center calls, what the Joint Commission wants a comprehensive stroke center to say is say yes, send them, auto launch, diesel fuel. I learned that new term this week from my paramedic friends. Instead of stop and go or scoop and go, it's like we need to do a diesel run. You pick up that patient at the primary stroke center and off you go to a comprehensive stroke center, whether it's by flight or by air. So we have a lack of true understanding within a region of how each and every hospital can network with a comprehensive stroke center. So the HERMES trial was a pooled analysis of 5 trials that were completed by July of 2016. And really the objective of that was to look at the best evident metrics. Why do we need to work so quickly when we take care of these stroke patients? Because we do know that we're losing synapses every minute, correct? Like every minute we're losing 2-minute synapses, and when you do that, it takes a long time for a patient to recover. So every single minute counts in a stroke code, and I see it in my own practice. Not everyone has that mentality. Every single person in a stroke code should have a clearly delineated role of what it is they need to do, because all of these patients require parallel processes. Someone's calling CAT scan, the CAT scan's getting ready, the patient needs to go, we need to do, the doctor is doing NIH or the nurse is doing NIH, we're given the TPA, and at the same time, you're on the line with the Comprehensive Stroke Center to make sure that this patient might be a candidate. That's not happening across the country. So there's a translational lag about some of the evidence that I'm talking about today. So the 2 groups that they really looked at in this particular trial, pooled analysis, meta-analysis, was the endovascular therapy group plus medical therapy. So we have a group of patients who met criteria and had IA therapy, and then we had patients who met criteria and only had best medical therapy. We talk about best medical therapy, we're talking about statins, getting the blood pressure down, looking at all the risk factors, getting them tightly controlled, a good plan of care while they're in the hospital, a good plan of care or rehab. So all of those things are bundled into that best medical care. That's what we're talking about. So what we're really talking about for these patients that were enrolled in these trials, which we now know are the patients that you should be considering for transfer, are the patients with a large vessel occlusion in the ICA or the M1 or the M2. These are the most common patients that we're going to consider for IA. Of course, there are other types of patients. And then they are treated with IV alteplase within 4.5 hours. They have an aspect score, which is a scoring system in which we look at a CAT scan to see how many territories were actually affected by ischemia. It goes from up to 10, with 10 being the best number. So as you get a lower score, that means more territory is actually affected by ischemia. So in this trial, most of the patients had an aspect score 6 or greater. And then the NIH, all of you are familiar with that score that people perform in the emergency room. We like to see an NIH score 6 or greater. And that you can achieve arterial puncture within 6 hours from last known well. So these are the facts. These are the things that you can rely on that are reliable, that as a clinician in the ED or in the ICU, if you're taking care of an in-house patient who had cardiac surgery and now they're having a stroke, or if you have a patient that presents with these kind of clinical manifestations, your ED doctors and your community neurologists should be calling the Comprehensive Stroke Center and saying, we have a potential patient here and we would like to transfer them down. So these trials, and I'm sure you all, if you were here last year, heard the great presentations that talked about the specific of the trials, involved 89 international sites. Now, I offered Dr. Wozniak I would be happy to travel to Italy or Paris to see how they did it, but she's like, no, we're not sending you there, Karen, don't ask. I also have asked Dr. Kittner if I could go to Oxford because some of the best work that's being done in stroke and looking at this, and he's like, no. So I get to go to Detroit. So I'm really happy about that, and I get to come to Christiana where I worked for years ago. And that's where I met my mentor, Coffey. So what were the primary outcomes that they were looking for? They were looking for the modified Rankin score at 3 months. A modified Rankin score is a disability score, 0 being no disability, and 6, you're dead. So that's pretty bad disability. And then some of their secondary outcomes, they were looking for functional independence at 3 months and the rates of mortality and hemorrhagic transformation. The results really were that the patients who had the procedure were better off at 3 months than those who did not. And so the odds ratio, you were 2.5 times less disabled at 3 months than those patients who did not have the procedure. So really, if I was a lawyer and I had a patient that met this criteria and I did not offer them IA therapy, you might be at risk for being questioned, why wasn't this patient considered? And also what this really did, in an overview with editorial by one of my favorite stroke authors, Dr. Claiborne, is say delays to treatment are associated with higher levels of disability. I didn't think we needed like 5 trials to come down to that conclusion. We do know that with IV TPA or IA TPA, any delays in treatment are associated with higher levels of care. So really, during the trials, what's interesting and what people say in the United States is like, oh, these trials were done in a country with socialized medicine where they had tremendous transportation systems and no problems with transporting from one center to another. As a matter of fact, the field providers were empowered to be able to send someone directly to a comprehensive stroke center. In the state of Maryland, EMS providers are prohibited by law to bypass a primary stroke center and go to a comprehensive stroke center. In Texas, there's a very famous doctor, and he will tell you he's famous, carries a cell phone in his pocket, and all the EMS providers know his cell phone, and they call him and they say, I have blah, 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 and I'm going to transport to your center. And he never says no. And guess what? The primary stroke centers in that area are not real happy that some of those patients are not first landing there, getting bundled, and then being transferred to a comprehensive stroke center. So the bottom line is, what I talk about is the need for speed, is that your groin time, from the door to groin time at a comprehensive stroke center, really from symptom onset, this includes from being in the field, going to the primary stroke center, now arriving at the comprehensive stroke center, including travel time, report time, transitioning time, is 238 minutes, will give you a good outcome. A good outcome is defined as a modified Rankin of 0, 1, and 2, which is you're pretty able and you're pretty able to take care of yourself. And then what we're talking about is the medium symptom onset time in the field, now primary stroke center, now comprehensive stroke center, now you're getting them on the angio table, you're getting your teams ready, and you're ready to go. And what happens is that reperfusion or recanalization time is just at 300 minutes. And so we are required as comprehensive stroke centers to ask our primary stroke centers for many time metrics, because we have to measure from the time they're in the field, the time the paramedic picked them up, the time they arrived at the primary stroke center, how long they stayed at the primary stroke center, when was the call made to the comprehensive stroke center, when was the decision made to transfer. And then what I'm really going to talk about here is the delay between the decision to transfer and time of arrival at comprehensive stroke center, which might not be an issue in Delaware, but is a big issue in other states surrounding you. And so really the question I had for myself is, this really could occur in our centers? Could this really occur in the United States? And we're struggling across the country with that. But being an optimistic and really wanting to take it down to simple terms, what the quotes that really stuck out to me, and of course there are some flaws in this pooled meta-analysis, But I think these two quotes really stuck home with me. For every 9-minute delay in symptom onset to reperfusion, for 1 out of 100 treated patients, they had a worse disability. So every 9 minutes, you are putting your patient at risk for having a modified Rankin of maybe 1 or 2. Now they're going up to 3 or 4. That requires skilled nursing home 24/7. So the faster you work in your center, the better off the patient is. And then for every 4-minute delay in the ED and door to reperfusion time, again, 1 out of 100 patients who are treated had a worse disability outcome. So essentially what we really need to do is work fast. So summary really is of this HERMES trial is that endovascular therapy compared to medical therapy alone results in lower disability at 3 months. And perhaps if you really want to stretch it, the time window isn't 6 hours, but in very specific cases might be 7 hours for very specific cases. So these are the time metrics the Joint Commission is going to adopt in July. They're saying that for the Comprehensive Stroke Center, once that patient arrives, you have 50 minutes for brain imaging to arterial puncture. In our particular hospital, we set it at 75 minutes. I'm happy to say we're below 70 minutes almost all the time. I'm going to tell you some of the best practices that makes that happen. 75 minutes for ED to door to arterial puncture at a Comprehensive Stroke Center, and then 110 minutes for ED to door reperfusion time. If any of you really want copies of these slides, I have my email at the end. I'm happy to send them to you. This is really the most important part of this discussion. When you have barriers in field triage or in the sending someone to a primary stroke center and then having barriers to sending one to a comprehensive stroke center is when you have poor outcomes for these patients. So field triage, we know our EMS providers are working fast, they're accurate, they still love ongoing education, we still provide them ongoing education, and they need to notify the primary stroke center. But I think that the accuracy of that base call into the comprehensive stroke center or the primary stroke center is dependent on the severity score and should they bypass the primary stroke center. That's a big debate. Right now, I think in most regions, I'm going to just say, I think probably we're not there yet. I think that we should go to the primary stroke center, get that patient bundled up, and then make decisions about going to a comprehensive stroke center. However, that's up to each region. I'm talking about nationally. Perhaps it's different in Delaware. So once that patient is in the comprehensive strokes and the primary stroke center, the question is, can you get a reliable NIH? And can you call that in to the comprehensive stroke center provider? Ideally, you can make decisions about CTA at the primary stroke level. We make the recommendation that if you have a patient with a high NIH stroke score, no bleed on their imaging, just send them. If you're going to have delays in getting a CTA to really confirm that occlusion, then I think it's best just to send them to the Comprehensive Stroke Center and they can actually identify that occlusion while they're on the table. But each region is different, and that's what you need to ask yourselves. So really in the Comprehensive Stroke Center, I think one of the best practices is having some kind of landing zone where each and every person is aware of what their role is, what they need to do in order to make the process work, calling MRI, calling the angio suite, where are the teams that are there meeting the patient, and really looking at your system to determine if you have a lack of ICU beds. The big debate right now really is, should EMS providers be allowed to bypass? And in the state of Maryland, we have so many primary stroke centers, and they're all very good. So we really have at this time have said we're going to do a pilot in the city of Baltimore in which EMS providers will be allowed to transport directly to certain comprehensive stroke centers if the field scores are a certain severity. So I really think the relationships between the primary stroke and the comprehensive stroke center are key. Collaboration, making sure you know the leadership at those centers are key so you can provide immediate feedback. Develop your alliances and share your time metrics is key. We've done that in the state of Maryland, and we've been able to improve our decision to door times by just sharing with them the urgency that we're having. I think that we, as comprehensive stroke centers, are obligated to give immediate feedback to the teams. So just last week, I started calling the primary stroke center ED providers and let them know what happened with their patients. We've been doing that for a while, but now it's consistent. We do case reviews with our other primary stroke centers, and that has been a key satisfier with our primary stroke centers. They love to get their data, and we're very transparent. So I think that one of the questions is, in the primary stroke center, if you're in a rural area, would you benefit from telemedicine? So I think the modes of transport need to be very detailed. When you make that call, make sure, are they going commercial, 911, flight? And we have a lot of regulatory standards that get in the way, but these are the questions you should ask your primary stroke center before they start working with a comprehensive. We have a checklist that we use in the state of Maryland, and I'm happy to send it to you. The primary stroke center fills out the checklist. It has everything we need on it at the comprehensive stroke center so that we can actually get going with that patient. And the most important thing is to have a cell phone for that decision maker that's going to help that patient make decisions. So really, what is the mission for all of us? And I think we all agree is that every patient deserves to be treated in stroke centers, which provides the level of care that will give them the best outcome. So there is a need for stroke-ready hospitals, primary stroke hospitals, and comprehensive stroke center hospitals. And I really think it's a collaboration. I think all those centers are valuable, and one is not better than the other, but we're all doing our best to get that patient where they need to be. If you want a copy of any of our protocols at the University of Maryland, or any kind of checklist or any kind of feedback forms we provide to the primary stroke center, please let me know, and here's my address. Any questions?